Hello, I'm Mamo Tosti and I'm the principal investigator for the project Spatiotemporal reconstruction with learned deformations. Together with me, there is Ozan Oktam, who is at the Department of Mathematics at KTH. I'm with the Division of Biomedical Imaging, also KTH. Other people who contribute to this project are Enza Cece, who is a PhD candidate from the University of Napoli, who's been on an exchange at KTH, and Hamid Reza Rashidi Kanan, who is a postdoctoral fellow that recently joined the group. Let me now start by giving the motivation for our work. Lung cancer is responsible for around 2 million deaths every year. And from the graph on the left, you might be able to understand that when the cancer is discovered at an early stage, so lesions are of the size of 1 centimeter or less, the 5-year survival rate is quite high, with as high as 92% or maybe something like 80% on average. Whereas when the tumor size exceeds 2 centimeters at the moment of discovery, the same survival rate drops to 10% or less. So there are many lives to save if we are able to image lung lesions at a very, very early stage. So now PET system resolution is around 5 millimeters, so it should be in principle possible to see 1 centimeter lesions. Unfortunately, here I show you a kind of realistic simulation of what a 1 centimeter lesion will look like in a PET image, and as you see, the contrast is not very high and there is a chance of missing this. So our goal is, of course, to move the PET images closer to the phantom where the lesion is clearly visible. Let me try to give you the reason why lesions in lungs are not visible. So let's start with a toy model where we have a small rectangle, a bright rectangle on a noisy background, and the rectangle is moving around during the acquisition time. If we are acquiring images of this rectangle for a long enough time, then we will be able to see it in the different positions. Of course, in this case, the rectangle is static in each of the acquisitions. But if you consider the case in which the full acquisition time is divided between these 3 positions in equal time, so 1/3 of the time, you see that the contrast to noise ratio of the rectangle drops significantly. And you might try to do something like, okay, I'll try to sum all this and I've recovered the full acquisition time. Unfortunately, of course, the contrast will be high enough just in the overlapping region, and then you will get some deformation of the shape of the object. So obviously what you would like to do is that you would like to move this rectangle to the left and this rectangle down before adding them up, and then you will get back a very nice image. Well, this would be what is presently done in practice. You just take the full data set and you add everything together, and this is what we propose to do. The real case is slightly more complicated. For the first thing is in 3D, so the object is not a rectangle, is some human being with, unfortunately in some cases, some lesions in their lungs. And we are able to divide the acquisition into different gates which correspond to different positions in the respiratory motion. And this in the respiratory cycle, and this is monitored with something. In this case, for example, is a belt with a piezoelectric sensor that measures the pressure from the chest. And as you see here, the lesion, here I'm plotting a slice through the patient, and where the lesion is in this particular position, which is full aspiration. But you see that the lesion is going to move not necessarily in the plane that I'm showing here, but it can also go in and out of the plane. So the situation might be even more complicated than what we have in the toy model, in the sense that these 2 gates, for example, would contribute absolutely nothing to the images for what the lesion is concerned, of course. So how are we going to try to solve this problem? Well, we have a further complication that I'm trying to convey here. That is that we don't really directly look at the object, if you want, as if we would do, for example, with a microscope or if we were taking pictures. While instead, we're looking at projections of the object. So you have kind of a set of objects, which are deformation of the object that you want to reconstruct. And then you have a set of measurements of their projections. And now what you want to do is that you want to, at the same time, from the projection, reconstruct the object, which is a complex enough problem to solve, and also estimate the movement, the deformation of the object, so that you can compose the two together in order to get a reconstruction of the object and the movement. So this is what we do here. We have modified the standard reconstruction algorithm for PET images, so to have, instead of just the forward model of the acquisition, the composition of the forward model of the acquisition and of the movement. Now, if you want to reconstruct the movement, you have to do some kind of registration in image space. And this would be, for a problem of the size of what we have at hand, a quite time-consuming task. So you will have the problem of maybe having to compute for few hours each time you want to estimate the deformation. Since you have few deformations and you have to iterate few times, this might take weeks, which is clearly unsuitable to the clinical workflow. Fortunately enough, you can use neural networks to do this in fractions of seconds. So I would really love to explain how the neural network we are using works, but you will have to contact me in person for that, because I have not time for doing that now. Let me instead show you some results that we have obtained with this method. So here you have the target reconstruction. This is the phantom, noise-free phantom. Here you might be able to see two lesions, one very close to the heart, which makes it even more challenging to see, and one slightly further away from the heart. And here you have a blow-up of a region of interest around one of those lesions. On the second column, you see the state-of-the-art reconstructions, what you have in the clinics. And as you can probably see, it's not easy to distinguish any lesion, and not even in the blow-up the lesion shows up. We have two methods that we propose for this. They are based on the rationale that I showed you before, but one of them does not need an X-ray CT for estimation of the attenuation map, while the other one uses a CT, which is routinely done together with a PET. And as you see in both of them, or I hope that you can, the two lesions are visible again, and in a blow-up you can appreciate that something is going on. In order to assess this in a more quantitative way, we have developed a channel isotelling observer, and here you see the receiver operating characteristic curve for it. In these curves, a simple way of estimating which is the best method is to compare the area under the curve. An area under the curve of 1 means that the reconstruction allows you to see everything with no false negative nor false positives, while an area under the curve of 0.5 means that you're just as good as random guessing. And here you see that the area under the curve for the two proposed methods is 0.78 and 0.77, while the clinical standard gets an area under the curve of 0.67. So from now, we would like to port these two methods to the real data. So in order to do so, we need to implement only the correction to raw clinical projection datasets, which is a bit of a pain because you need to be able to understand what the vendors are doing and how they are compressing the data, and they are not really telling us how they do it. And then we have to add scatter correction to the algorithm, which in principle is not difficult, but in practice it will require some work. And then we will apply the two algorithms to patient data and evaluate their performance with the help of the channelized hoteling observer, but also of radiologists at Hotinge Hospital that are collaborating with us. And we have, of course, an ethical permit for acquiring data for that. So, thank you very much for listening, and if you want to get in touch with us, please contact me or Ozan. Here are our emails, and maybe come for the in-person presentation and ask questions and discuss with us. Thank you very much.